Moving on to our first slide, we have an overview of the arterial histology. As a general rule, all blood vessels, with the exception of capillaries, have smooth muscle and connective tissue. The vessel lumen is lined by endothelium, which is a squamous epithelium, and the endothelium acts as a semi-permeable barrier that supports molecule exchange through diffusion, endocytosis, and also transcytosis. The endothelial cells align with the direction of the blood flow and the rest on the basal lamina. On the right, you can see an image where it's a histological slide showing the cross-section of an artery, a vein, and a capillary, highlighting the differences in layers. And some of these components will take a deeper dive in the next couple of slides. This slide details the critical function of the endothelial cells, which go far beyond just lining the blood vessel. They play a major role for regulating blood flow, and they cause vasoconstriction by releasing chemicals. Some chemicals like the endothelin 1 and ACE can cause vasodilation. They can cause vasoconstriction by releasing compounds like endothelin 1 and ACE. They can also cause vasodilation by releasing nitric oxide and also other chemicals like prostacyclins. These prostacyclins also inhibit platelet aggregation. The endothelial cells are also crucial for immune responses. They help recruit any white blood cells, utilizing a signal called P-selectin, which is released from the Weibel palate bodies. And in terms of the hemostasis, they also release chemicals like heparin, which is an anticoagulant that prevents any clot formation. And also TPA, a tissue plasminogen activator, which dissolves the fibrin clots. They produce the von Willebrand factor, which then aid in the platelet adhesion during clotting. A clinical correlation here is that the dysfunction of the endothelial layer is oftentimes the first step in development of many kinds of cardiovascular diseases. And as a damaged barrier allows for initial infiltration of lipids and inflammatory cells. An example would be like aspirin, which is a common medication that works by inhibiting the prostaglandins like prostacyclins, can help reduce platelet aggregation. Our types of blood vessels. Next, we'll look at the three main types of blood vessels. Arteries are thick-walled, high-pressure vessels that carry oxygen-rich blood away from the heart. Veins are thin-walled vessels with wide lumens that return low-oxygen blood back to the heart. And lastly, we have the capillaries, which are the very thin-walled vessels where exchange of oxygen, nutrients, and waste products occur. The circulatory pathway involves blood leaving the heart via arteries, which branch into arterioles, and then reaching the capillary beds. And from the capillary beds, they flow into the venules and then drain into the veins. And then finally, they return to the heart via the superior and the inferior vena cava. The pulmonary circuit, for example, is a low-pressure system, unlike the high-pressure systemic circuit, which has a clinical relevance for conditions like pulmonary hypertension, in which there's an elevated pressure in the pulmonary arteries, and that can ultimately strain the heart. And on the right, you can see a visual showing you the transitioning of the big vessels from the heart and then to the peripherals of the body and then back to the heart. Notice the size difference between the smooth muscle of a vein and the artery. And on letter C, you can see how the lymphatic vessels scatter around the arterioles and the venules. And these capillary beds are super small. The structure of blood vessel walls. Here we're going to break down the structure of blood vessels, which are composed of the three key layers, or tunics. The innermost layer is called the tunica intima, which is made of endothelium and connective tissue. Capillaries are unique in that they consist solely of this layer. And the middle layer is called tunica media, which is primarily smooth muscle and is the most variable layer among the blood vessel types. And then the outermost layer is called tunica adventitia. This is a connective tissue layer that provides support and structure. And in arteries, the tunica media is thick with elastic fibers to handle the high pressure. And in veins, the tunica media is thinner with less fiber and less muscle. One of the clinical points here is that in chronic hypertension or high blood pressure, it can lead to hypertrophy and thickening of the tunica media in muscular arteries, as the smooth muscles proliferate and compensate for this increased pressure, which can in turn lead to the stiffening of the vessel wall. So on the right, you can see a cartoon image showing you the different layers, the intima, media, and then the adventitia. Histological stains used. The slide is critical for understanding the histological stains you'll see in the next couple of slides. And we're going to visualize this with several types. We have H and E. This is called the hemotoxin and eosin stain. It's standard stain for general tissue morphology. And with this kind of stain, the nuclei appear blue, while the cytoplasm, the collagen fibers, and the muscles stain pink or red. Next, we have the elastin stain. This is also known as the Werhoff or Orsian. This stain is excellent for visualizing elastic fibers, and they stain them jet black. This is useful for seeing the elastic laminae inside the arteries and the internal and external elastic laminae. So the use of this elastic stain is clinically essential for diagnosing any kind of connective tissue disorders like Marfan syndrome or deficiencies in elastic fibers that could lead to aortic dissections, thinning it out, or even aneurysms. So on the right, you can see how the coloration looks, a little bit of dark stain of the fibers all over. And over here, the nuclei are stained all around. Now let's take a look at the aorta, artery versus the vena cava vein. This is a slide comparison of the largest artery, the aorta, with the largest vein, the vena cava. So the first one is the tunica intima, letter I. You can see both are lined by the simple squamous endothelium, and it contains subendothelial connective tissue. However, we do see the internal elastic laminae. This is called the IEL. This is present in arteries, but it is absent in veins. Then we can take a look at the M, media. This is arteries usually have a thick media with alternating elastic laminae and smooth muscle, while veins have a thinner media with fewer elastic fibers. And the final layer is the letter A, tunica adventitia. This is thicker and large veins than arteries and contains elastic fibers in both vessels. And you can see that small little V, the vasa vasorum, embedded inside the aortic adventitia. So that's right here, these small little tiny vessels of V. And notice the IEL, which is that intima, internal elastic laminae that you do not see over in the vein side. And then of course the thickness of the media. This is the artery, whereas on the right side, this is the vein. Next, let's take a look at the vasa vasorum. The vasa vasorum are a network of small blood vessels that are found inside the tunica adventitia of large arteries. They include arterioles, capillaries, and venules, and provide metabolic support to the outer layer of the vessel wall. The slide here shows you that there is sparse nerve supply in the adventitia. This is consisted of sympathetic nerves. We abbreviate that as N inside the image. Over here, nerves. And these nerves can regulate the vasoconstriction by acting on the smooth muscle of the tunica media. And a clinical application here is that any kind of inflammation or occlusion of the vasa vasorum, this is a condition known as aortitis that can lead to weakening of the aortic wall and even lead to the formation of an aneurysm. And this is oftentimes a complication seen in patients with syphilis. Next, let's take a look at the elastic artery. The tunica intima, a letter I, is lined by the endothelium over the loose connective tissue, and many contain smooth muscle. It also features an internal elastic laminae, the IEL, with fenestrations for diffusion. Then we have the letter M, tunica media, which is a prominent layer where multiple concentric layers of this helically arranged smooth muscle are interspersed with the elastic fibers, reticular fibers, and even proteoglycans. And in the larger arteries, it may include that external elastic laminae. And then the final is the tunica adventitia A. This is composed of the dense irregular connective tissue, mostly type 1 collagen fibers, and elastic fibers, and provides the structural support for housing those smaller vasa vasorum within. The elastic nature of these arteries is what allows them to act as a pressure reservoir. The loss of any of these elasticity as we age is referred to this condition known as arteriosclerosis, and it leads to a higher systolic blood pressure and a wider pulse pressure. Over here you can see the adventitia layer, and then over here you can see the media layer, and then the intima layer over here. This slide is just a visually enhanced view of the aortic histology. It helps you clearly distinguish between the different layers with a black background. You can see the tunica intima, the media, and the externa very clearly, as well as the vasa vasorum and the elastic laminae. The elastic artery continues. So to elaborate on these elastic arteries, their tunica media contains up to about 50 layers of elastic laminae. The elastic fibers stretch during systole, which is the contraction of the heart, and to buffer these pressure surges from the heart. Then during the diastole, the relaxation, these elastic recoil helps maintain the pressure and ensures a continuous blood flow. The recoil reduces any kind of pulsativity. The tunica intima has a subendothelial smooth muscle and is prominent internal elastic laminae, the IEL, which helps facilitate any diffusion and provides structural integrity between the layers. You can see that the tunica adventitia is relatively thin, but does contain the vasa vasorum throughout. Over here are the vasa vasorums and the tunica adventitia. And over here you can see the elastic fibers. And then over here we have the IEL layer right at the endothelial layer. Atherosclerosis and elastic arteries. So now for a key clinical point, this condition of atherosclerosis. This condition affects elastic and large muscular arteries and begins with any kind of endothelial injury and the oxidation to the LDL and the intima. This oxidized low-density lipoproteins attracts white blood cells like monocytes, which will then eventually transform into these macrophages that then turn into foam cells. These foam cells, along with the lipid, form these fatty streaks, which are the early signs of these lesions. This then progresses into this fatty plaque known as the atheroma, and any kind of risk factor, including having a high LDL to HDL ratio, diabetes, overweight, hypertension, can lead to these muscular arteries, like the coronaries, to be having a more narrowing of a lumen. And this causes chances of ischemia, cutting off the oxygen supply, and infarction. And on the right, you can see a picture of the atheroma right here, blocking the lumen, so there's a lot less space for the blood to flow. So on the bottom, you have a cartoon image showing you that yellow region of the plaque, and then eventually potentially causing a clot called a thrombus. Arterial chemoreceptors. Moving on to arterial chemoreceptors, the carotid sinus are dilations at the base of the internal carotid arteries. They function as baroreceptors to monitor arterial blood pressure. The tunica media here is relatively thin and allows the wall to distend with increased pressure. Chemoreceptors on the other side are located at the carotid and aortic bodies, and they're part of the ANS, autonomic nervous system. They contain a set of cells called the glomeruli cells, which are dense core vesicles that house the neurotransmitters like dopamine, acetylcholine. One of the clinical techniques here is the carotid sinus massage, which can be used to stimulate the baroreceptors and slow down a patient's heart rate in certain types of tachycardia. So by just generally pressing down on the carotid artery, you can slow down the amount of blood going up by activating the baroreceptors. You can see right here that between the splitting, the bifurcation of the external and the internal carotid artery, there is a chemoreceptor, the carotid body right there, that picks up a change in the blood flow. Let's take a look at the glomus body. So these are located in the walls of the elastic arteries near the common carotid. The primary function is to act as a chemoreceptor to monitor CO2, oxygen, and protons concentration in the arterial blood. They're really rich in large capillaries and contain glomus cells, which is expressed as G here. And these glomus cells are derived from the neural crest, and it contains vesicles filled with dopamine, acetylcholine. Letter S stands for satellite cells. These are one of the neuroglia that have elongated nuclei surround each of the glomus cells. Some of the key stimuli include these conditions like hypoxia, hypercapnia, having too much CO2, and acidosis, too much protons. Over here you can see the satellite cells and the glomus cells. And these are the large capillaries. Let's take a look at the muscular arteries, distributing arteries. Muscular arteries are also known as distributing arteries because they have some key differences from the elastic ones. Starting with the tunica intima, it has a thin subendothelial layer and a prominent internal elastic laminae, the IEL, and is oftentimes very wavy in histology. The tunica media is dominated by about 40 layers of smooth muscle cells, and they're interspaced with elastic laminae, though fewer than those inside the elastic arteries. The media is thicker than the elastic components, and the external elastic lamina is present only in larger muscular arteries. Then the final tunica adventitia contains the vasa vasorum. It has lymphatic capillaries and nerve fibers that can penetrate. Clinically, whenever there are vasospasms or sudden contractions of the smooth muscle inside the tunica media of the blood vessels of the heart, this can cause angina, which is a type of chest pain. More specifically, what they call the Prismetal's angina. Over here is letter E, the endothelial cells. Then we have the IEL. Next, we have the arterioles. Arterioles are the smallest arteries and play a crucial role in the blood flow regulation. The tunica intima is extremely thin and lacks the internal elastic laminae. The tunica media consists of only one or two circular layers of smooth muscle. And then the tunica adventitia is a thin, inconspicuous, and functionally, arterioles have these small precapillary sphincters at the end to help regulate how much blood goes through into the capillaries. Partial smooth muscle tone can provide resistance, which can control the flow rate and is a determinant of systemic blood pressure. When there's widespread relaxation of these precapillary sphincters, it could cause a massive drop in blood pressure. And this can cause the TPR, the total peripheral resistance, to plummet down. So you can see right here, these sphincters control the flow of the blood across, and when they're all constricted, it's going to go faster, increasing pressure. When it completely relaxes, it might drop down the pressure. This slide here shows you three different histological views of the arterioles. In image A, you can see that the arteriole has the intima, letter I, and is made up of the endothelium, the E, with a rounded nuclei. The media, which is M, contains 1 to 2 layers of smooth muscle, and then the adventitia, letter A, is thin and oftentimes inconspicuous. In image B, you can see the three arteriole A with varying sizes and capillaries C. And in the image C, you'll be able to see some of the key smooth muscle layers in M, which is actually cut out. Microvasculature, arterioles, capillaries, and venules. So let's take a look at the microvasculature. The arterioles are expressed as letter A, and they regulate the entry of blood into the capillary beds. Capillaries are letter C, and are primary site of exchange between the blood and also the interstitial fluid. And the veins, which are V, collect the blood after exchange has begun, and they return the blood back towards the heart. And a key feature of capillaries is their small diameter. They range from about 4 to 10 micrometers, and they lack any tunica media as well as tunica adventitia, and they're being only exposed with a layer of endothelium in the basal lamina. So any kind of excess fluid becomes lymph, drains into the thin-walled irregular vessels called the lymphatic vessels, which is shown here as L. These lymphatic vessels. And this slide shows you the visually enhanced view of the muscular arteries and the vein. And 3 images below highlight the color code of the tunica intima, the tunica media, and the tunica externa. On the right, you see the 3 layers. And over here, you can also see the group of vessels, the nerve demonstrating how they are often found together in the body. And you can see the muscular artery, the arterioles, the venule, the medium-sized vein, and also the peripheral nerve over here. Arterial anastomoses and collateral circulation. Anastomoses are connections between multiple branches of an artery. Their importance lies in providing potential detours for blood flow if the usual pathway is blocked, and this allows for collateral circulation. In case of obstruction due to any kind of joint position, pathology, or surgical ligation, these collateral pathways are smaller alternative channels that can expand over time and maintain the blood flow from that blockage. However, it is important to note that they need time to develop and are generally ineffective for sudden blockages. So some areas of the body also lack adequate collateral circulations. So an example would be the famous coronary artery bypass graft, called the CABG, CABG, is a surgery that allows you to create an artificial anastomoses to bypass a blocked coronary artery and help restore the flow to the heart muscle. So beyond the typical artery, capillary, vein pathway, there are alternative microvascular routes. The AV shunts, arterial venous routes, are found in the skin, and they allow for direct flow from the arterial to the venule, bypassing any capillary. And this is one key example for temperature regulation. Another one would be the venous portal system. This is a unique pathway where blood flows from 2 capillary beds separated by a portal vein. And this system enhances a localized delivery of hormones, nutrients, and the sequence of blood flow here is different, is the efferent arterial to the capillaries than to the efferent arterial. In cases, there could be arterial venous fistulas, which are created surgically in a patient's arm for dialysis, is an example of an arteriovenous shunt that provides high flow access point of blood, which can be very important for treating renal failures. Capillaries generate metabolic exchange between the blood and tissues and form networks called capillary beds. Capillary beds are high in kidneys, liver, and striated muscle, while they are low in smooth muscle and dense connective tissue. Structurally, they are an endothelial tube with a basement membrane with a diameter about 4 to 10 micrometers and a length of about 50 micrometers. At any given time, only about 5% of the body's blood volume is in the capillaries. This equates to about 300 mLs of blood. There are three key types: the continuous, the fenestrated, and the discontinuous, also known as sinusoidal. Over here on the right, you can see the size, the adipose tissues over here, and the capillary over here cross-section. And then you can see some of the red blood cells actually flowing through the capillary called the relu. Capillaries with parasites. Parasites, or P in this image, are contractile cells associated with capillaries. They are important for supporting capillary stability, permeability, and repair. The endothelial cells, again E, which have flattened round nuclei, form the capillary lumen, and the rest is going to be the basal lamina, the BL. That's the basal lamina right here. And they're connected by tight junctions, which is shown as J. So these are junction points of the gluing them together. And they're critical for maintaining structures like the blood-brain barrier, and damage to the parasites can lead into increased permeability of this barrier. So it's believed, not 100%, that in some pathologies like Alzheimer's, there could be some sort of a reduction of the parasites that lead into the cerebrospinal fluids. Continuous capillaries. They provide the tightest barrier control. The endothelial cells, E, form a continuous lining of the lumen, which is the L in this image. And they're connected by tight occluding junctions. Again, the JC, these are junction points where they're blocked off. And this means that all substances must pass through the cells themselves via simple diffusion, or even through the cells through a vesicle, which is V, called transcytosis. So the V right here represents these small little vesicles by which they can move stuff through the cell. These capillaries are surrounded by the basal lamina, the BL, the parasite, the P extensions, and of course there's a lot of collagen all scattered around. So the C here represents the collagen fibers. Sinusoidal capillaries. These are the discontinuous capillaries that are opposite of the continuous capillaries. They have high exchange, subpermeable vessels. They are also wider in diameter than typical capillaries. Their endothelial cells are very thin and have large fenestrations within the cell, as well as discontinuities between the cells and inside the basal lamina. Histologically, their nuclei are less visible, and you'll find these in organs like the bone marrow, where most of the hematopoietic cells, the H, representing these early stem cells, and A, adipocytes, are found. These are fat cells. They're found inside the liver, the spleen, and they do provide a relative degree of permeability. Next, we have the fenestrated capillaries. These are specialized for rapid exchange of molecules, and you'll find them in spaces that require rapid exchange. For example, hormone uptake by endocrine glands, or for filtration of outflow inside the kidneys. Their endothelial cells usually have multiple small fenestrations, small pores, that are closed by diaphragms, and this allows greater permeability than the continuous capillaries. But their basal lamina does remain continuous, preserving that vessel integrity. One application here is in hypoglycemic patients for diabetes. You will see damage to these capillaries. This can lead to a thickening of the capillary basal laminae, which can impair the function and contribute complications and lead to like retinopathies and neuropathies. Overview of the veins. Now let's switch gears and look at the veins. We'll classify them into three main types based on size. Venules are the smallest veins, which drain capillary beds and join to form small veins. An example will be the dorsal venous arch of the foot. The medium veins drain venous plexuses and accompany medium arteries. A key feature of the medium veins is that they contain valves that prevent backflow and assist with unidirectional blood flow toward the heart. Examples would be the cephalic and the basilic veins, as well as the great and small saphenous veins. Large veins, like superior vena cava, are characterized by wide bundles of longitudinal smooth muscle and develop tunica adventitia. Any failure of these venous valves, especially in the great saphenous vein, is a primary cause of varicose veins and chronic venous insufficiency, as the blood then pools into the lower extremities. Venules. Let's take a closer look at venules. Postcapillary venules, shown as V in the image, have a large lumen and only an endothelial lining or an intima. They're surrounded by occasional parasites, which is shown as the P, but no smooth muscle. These venules are the primary site for the white blood cell, WBC, in diapedesis extravasation, where WBCs can adhere to and migrate across the endothelial as sites of inflammation or infections. And clinically, this process of exacerbation is the cellular basis for inflammation. Drugs like corticosteroids work by suppressing this process, thereby reducing inflammatory response. The muscular veins are slightly larger and begin to develop a defined tunica media. They contain 1 to 2 layers of smooth muscle, shown as M, and they oftentimes have a more distinct tunica adventitia, AD, in this image. So over here you can see the AD, tunica adventitia, and you can see about 2 layers of smooth muscle in the larger ones, whereas in the smaller ones you can't really see much. This is a vein versus a capillary versus an artery. Median veins. The tunica intima is thin. The tunica media contains small bundles of smooth muscle mixed with reticular and elastic fibers. The most distinguishing feature here is that the median vein is thick, collagen-rich, and well-developed, whereas the tunica adventitia, the images on the slide provide this excellent histological view, showing you these layers clearly. You can see it's pretty collagen-rich all around. Let's take a look at the small vein versus the muscular artery, a direct comparison. So this slide provides a direct comparison between the small vein and muscular artery in the same histological sections. So this gives you a perspective of size. The small vein is shown as letter V that has a large lumen relative to its thin wall, which has 2 to 3 layers of smooth muscle and its tunica media. In contrast, the muscular artery, which is letter A, has a much thicker tunica media, which is also M, and also thicker adventitia, the AD. In image B, you can see the key features of the veins. There's this valve, the venous valve shown by the arrow, which is a thin fold inside the tunica intima that projects into the lumen that helps prevent backflow. And then the third image, letter C on the bottom left, you can see the median vein, which is the MV, versus the muscular artery, the MA. Comparison, side by side, highlighting how the vein has a thicker wall than a small vein, but is way less defined than its accompanying artery. Now let's take a look at the large veins, like the vena cava, which have distinct features. The tunica intima, the letter I, contains subendothelial connective tissue that projects into the lumen as a valve, shown as V. This is the valve region. And tunica media, the M, contains smooth muscle, but is relatively thin, and it's a very thin muscular layer compared to the surrounding of the adventitia. This is the adventitia region over here. And then the M is the tunica media muscle layer. I right here is the intima. Clinically, any kind of postcapillary venules have the loosest endothelial junction, which can lead to plasma leakage into the interstitial space. And this is oftentimes resulting of edema. This slide is similar to the one we saw before with the muscular artery, and it shows you an enhanced view of the median vein. The color-coded images gives you this highlight to the tunica intima, the tunica media, and tunica externa. This makes it easier for you to identify these layers in a histological slide. Some of the unique characteristics and functions of veins. Veins have the unique structural and functional characteristics. Their walls are thinner, especially the tunica media, compared to the arteries. They also have a larger diameter and a higher capacity for expansion. The crucial function is the presence of those venous valves, which help prevent backflow to blood and ensure that blood is unidirectional towards the heart. The musculovenous pump assists in overcoming gravity, especially in the limbs, aiding in the blood return to the heart. Then we also have the arterial venous pump that also drives the venous blood towards the heart. One of the clinical considerations here is that when you sit for a long period of time or standing, it can weaken the venous pumps in the system. This can contribute to the formation of DVT, deep vein thrombosis, which is a potentially life-threatening blood clot inside the deep vein. So it's very important to stretch and move around. Systemic vein and venous return mechanisms. The systemic veins are more variable in their paths and structures than arteries, and have frequent venous anastomoses, which are these natural connections that we talked about between veins, and provide pathways for blood return. We can also have them both superficial and deep veins. The deep veins are located within the regions around the musculoskeletal region and are assisted by muscle contraction and also the musculovenous pumps. The outward expansion of the contracting muscles is limited by the deep fascia that creates this compressive force like a sock around your leg or your ankle and propels the blood against gravity. The superficial veins are located outside the deep fascia and are not directly affected by the muscle contraction. And these are assisted by perforating veins that help shunt blood to the deeper veins. Another clinical application would be the varicose veins. And finally, varicose veins are when there's abnormally swollen or twisted veins, typically in the legs, and they're caused by a loss of elasticity in the vein walls. This can cause them to dilate under pressure, and major cause of this is related to incompetent valves, which don't really close properly, resulting in an unbroken column of blood that increases the pressure of the vein wall. Some of the factors that can exacerbate this condition include a degenerated deep fascia, which can no longer contain the expansion of the contracting muscles, and also ineffective musculovenous pumps. And last but not the least is here's a simplified chart table that goes over the key major blood vessels that we discussed today, as well as each type, lists the approximate outer diameter, the key features of each wall layer, and their role in the circulatory system. This helps as a study guide for you to review and differentiate between the elastic arteries, muscular arteries, arterioles, capillaries, and of course the different types of veins.